Presenting before you a doctor who has given many hearts a new lease of life. Dr. Naresh Trehan, an MBBS from the KG Medical College, Lucknow. He has done his specialization in cardiothoracic surgery from the US. He was the founder, executive director and chief cardiovascular surgeon of the Escorts Heart Institute and Research Center, New Delhi. Presently, he is the chairman and MD of Medanta, the Medicity, a multi-super speciality institute offering world-class healthcare services at an affordable price. He has been conferred with many prestigious awards, including the Padma Shri and Padma Bhushan, and also holds the distinction of being the personal surgeon to the President of India. Ladies and gentlemen, please welcome on stage Dr. Naresh Trehan to connect with your heart.
Ladies and gentlemen, presenting you Dr. Naresh Trehan to address on sickness to wellness, the new health management.
Thank you and good afternoon. I appreciate this privilege of being amongst all of you and quite impressed by the organization and the music and the drama that you have created, so it almost parallels Bollywood. So what I was going to talk to you about today was more somewhere, it's a start. Let me just get back my cue back here. Okay. The history of Indian healthcare in an organized fashion is quite recent. In the sense that if you go back to my personal history, and I'll share some of it with you, that while in medical school, which was in King George's Medical College, we would see patients who we knew what disease they had. We knew there was treatment available in the world, but we also had the frustration that that treatment was not available to our patients in India, so we would see them die in front of our eyes. With that frustration, we grew out and said, let us seek the training and the knowledge from the Western world where we should be able to come and apply those technologies back to our own people. So that's when I went to the United States and was fortunate enough to get training at New York University under the tutorship of Dr. Frank Spencer, who happens to be one of the best teachers of heart surgery in the world, but also it was the early days of bypass surgery. Bypass surgery had just started. When I finished my training in 1979, many patients from India, about 300 of them a year, would come to New York for me to do their bypass surgery at a cost which was prohibitive. In those days, it used to cost $10,000 to $15,000 just for the surgery. And also they had to come with their families and bear the expense of them staying outside in all inclement weather which they were not used to. So everyone had the same thing on their lips. Why cannot it be done in India? Why do we have to come here? And also the realization that for every Indian who could travel overseas, there were thousands who needed it but could not access it. So with that, the whole story started of trying to see what are the possibilities of coming back to India. And very soon, with all the invitations that I got from different hospitals to come back and start heart surgery, it was quite clear that I could, in a few chosen hospitals, start heart surgery, but it would not lead to anything beyond just my personal practice, so that we could not train people there or we could not do any research on cardiovascular disease. So we started the journey of building our own hospital at that time, because none of these hospitals that I just showed you had the ability to support a full-fledged heart training hospital or a heart institute. That's why I studied it in detail and set out to build a institution where you could provide the best of cardiac surgeries and cardiology treatments, but at the same time train our own Indian doctors, cardiologists, surgeons, and so on and so forth, and also start research for how to treat our own people, because genetically we are different from the West, where we got our knowledge from. So this led to, in 1988, the culmination where we built Ascot's Heart Institute and I returned back to India. In short period of time, because the demand was huge, it became one of the largest heart institutes, and I'll come and revisit it again later. But I wanted to tell you at that time, my interest started in healthcare India, because it was very clear that we had huge deficiencies in our healthcare system, and 90% of Indians were out of the healthcare loop. Also, on a daily basis, you hear the political slogan that health for all by 2000. With little bit of research, I found that that slogan came from the Alma Ata Declaration in 1978, where India, along with 134 other countries, signed a declaration saying that they will provide minimum standard of health care to all their citizens by the year 2000. So in the year 2000, it was very clear that we had nowhere in sight the goal that we had set in 1978. So we commissioned McKinsey to do a status report for us with two questions. According to the standard that was promised in 1978, which was supposed to be accomplished in 2000, where are we as a country? And if we are not there, what will it require in the next 10 years to get there? So the answers that came up about where we were, if you look at the regular indicators of healthcare of a country, that is by the number of beds per thousand population, the number of doctors per thousand population, and the number of nurses per thousand population, it became very clear that we had reached about half of where we should have been by the year 2000. Similarly, if you look at the indicators of health level of our people, there were many improvements, but we were still lagging behind badly as compared to some of the other countries like China, Mexico, and Thailand, which had also signed the Alma Ata Declaration along with us in 1978. So if that gap existed, what were the reasons for it? One point was that 80% of all spend on healthcare came from people's private pocket, not from any insurance company or not from the government. So if that be, the affordability for healthcare by individuals in India was very limited, because there weren't that many people who could afford to go private and access healthcare. So we said, okay, if we are going to understand what does India have to do in the next 10 years, we must understand how much are we spending as a nation on healthcare and how much is the government contributing to the spend of healthcare. So if you look at this slide, you will see that our GDP spend on health in the year 2002 was 5.2%, out of which the government had only spent 1%. 4.2% of the GDP came from private pockets. And if you look at, compare it to the graph on the right, that we spend even 1/10 of some of the developing countries on health per annum per capita. So with that in mind, we said, what should we be doing to take the next step or a deeper dive? So we say, India, on one hand, I gave you a dismal picture. India, on the other hand, had high ends of creative medical centers where you could actually deliver healthcare at international levels at 1/10 the cost. So we had this advantage, albeit very small, at a tertiary level, big gap in the middle, and then the rest of the healthcare system was actually not performing as well as we should have. So with that advantage of providing healthcare at an international standard and fraction of the cost, we started seeing a lot of people coming to India from overseas to access health. So there were three ways they would come. One is India was the traditional provider of high-end healthcare to SAARC countries, because there was a gap between their development and our development of healthcare. As you may notice that many of our physicians and surgeons overseas in America and in UK have achieved the highest level of healthcare delivery system. So if our talent was already recognized all over the world, what was needed was to multiply the facilities by which our doctors could practice safe medicine. So with the help of some internal, inward-bound medical tourism, we got a lot of encouragement to say India can move forward like in many other sectors in the healthcare delivery system, not only to our own country, but also to countries as far as the United States. So we have now a mixture of patients coming in from different countries. Like I said, the majority will come from countries which are in our neighborhood, where good quality care is not available in their own countries. The second is countries which are semi-developed, only high-end care is not available in their countries, so the specialized procedures like we do robotic heart surgery, we do robotic prostate surgery, we do many of the cancer treatments which are not even present in developed countries. So those are the attractive points for us to bring in people from all over the world. Now it does two things. One, of course, it boosts the confidence of Indian doctors and paramedical personnel to say we are competing with the rest of the world and we have an opportunity, if we get our act together, to be one of the best medical systems as far as quality is concerned. The second, it brings in, of course, foreign exchange, which can cross-subsidize Indian patients whenever we need to give them heavy-duty concessions because they can't afford care. So if we do it right, medical tourism, if we multiply it as the opportunity is there, we will be able to reduce the cost to our own patients, because a lot of these costs can be amortized by foreign patients. So when we ask the question, what would India need for the next 10 years? So the goal was 2012, that we will need to double our infrastructure. That means another 750,000 beds, 1 million more qualified nurses, and 500,000 more doctors, and an incremental investment of about $30 billion. So if that was the goal, what were the things that we needed to do? So we needed to say that willy-nilly just growth of a healthcare system does not amount to good quality care. So we needed to define the standards with which we should create new facilities and benchmark the quality of doctors that are going to be trained. So things to recognize at this stage was that we had now seen, as I showed you in an earlier slide, that the longevity of the Indian was increasing. We had, at independence, our average age was 37, and now if you look at it today, it's more than 65 years is the normal life expectancy of an Indian. As usual, women will live 2-3 years longer than men. But what came out very recently is that the last 15 years of an average Indian's life is going to be spent in some ailment, with some ailment or the other. So what we are saying is we are living longer, but we are not living healthier longer because of our social habits, our dietary habits, our exercise habits, that we tend to take a downward spiral as soon as we cross 50-55 years of age. So that is something that was in the back of our mind when we are creating new facilities. Also, the needs of an older population also change what we call geriatric medicine, and that we must make our hospitals and healthcare facilities oriented towards them. And more importantly, insurance had to be encouraged so that more and more people could get access to healthcare without having to spend all their savings at the time that they needed medical care. So that was to be encouraged. And of course, some of the other things, technologies that have come to our rescue to actually do remote medicine, to treat patients at home more effectively, those were things to be leveraged so that the Indian healthcare system in this given period could be proud of delivering care to many, many more Indians than it did in the year 2000. But at the same time, we have to face the fact that large portion of our population is in the rural areas, but they get the least spend on their health. So we are saying that in the beds, there is an skewed presence of our healthcare infrastructure. And that had to be corrected somehow over a period of time. So what did we do? In this early stage of 2002 onwards, we engaged with the government, and the government also became acutely aware that unless healthcare is provided to our population, it will become an issue. So education and healthcare did progressively get center stage in our thinking, not only in the private sector but also the government sector. Albeit the government did not allocate much more resources, but in the 12th plan, which has just started, they have promised to double the spend on healthcare from 1.2 to 2.5% of the GDP or the budget. So in this, the government started the NRHM, which is the Rural Health Mission. Also in the Rural Health Mission, they launched many programs, including providing ASHAs, which I'll talk about later. But these different Bima Yojanas and insurances by states actually made it possible for everybody to be able to access healthcare to a level of 50 to 60,000 rupees a year because of these free insurance schemes by different governments, that is central and state combined. So that helped a lot. And then there were some initiatives which were started by us and many other people to say how can we help to provide health, because one of the biggest gap was that we live so unhealthily in our villages. So what we did was, we said, unless we correct that anomaly of a village which has no clean drinking water, no hygiene, no education, we can spend all the money we want to, we will never decrease the disease burden. So we started this project in which we took 5 aims. And the basic thing was to provide clean drinking water, sewage system, mosquito control, education, and a sanitation drive so that the garbage disposal could take place in a proper manner. So we took this village, Joniawas, which is near Delhi. Residents of 2,000 people live there. And we found that this was a dismal state because the sewage system was flowing through the homes. Garbage was dumped in the back of the home, and there was like disease everywhere. So what we did was we actually took that project, and these are some of the pictures from the early stage, and then we actually made a sewage system, open drain sewage system connecting all the homes into a septic pit. We changed the drinking water, the depth of the well till it became drinking water, just put 4 walls for a garbage dump, and created some toilets and refurbished the school so that the children would go back into the school. These are little things which cost us 12.5 lakhs of rupees. 70% of the work was done by the villagers, and then we brought the villagers, the panchayat guys, and trained them how to maintain all the stuff. So this was our first pilot project, and we had all these corporates who participated in making this village a healthy village. For example, the clean drinking water was worked out by Punch Lloyd and Coca-Cola. We had the HCL guys give free computers to the school, and so on and so forth. So we had then created now 100 villages which are in this program, and this blueprint is available to anybody who wants to get into it. At the same time, when this was happening, we also felt that if India is to actually be independent, not have the prefix of underdeveloped country, then developing country, then almost developed country, and then now emerging market. So they don't say India is India, and we realize that India will not be called India till we take charge of our own destiny. Medically, what it means is, as I just told you, and I'm one of those people who went overseas, learned something, copied it, and came back. And we are still proud of copying the West. Let them be developed, it comes off patent, and then I will copy it, and I'm a great guy. It may be true that we needed that at some stage in our life of our country, but that's not the future. So in 2003, we started thinking what was missing in India. What was missing in India is that we did not have institutions like Harvard, like Mayo Clinic, like Johns Hopkins, Stanford and all, where not only were they delivering the highest end of medical care, but also all new knowledge came out of those areas so that they will devise new remedies for their population, which may or may not apply to populations like India, because certainly it would always be much more expensive than India could afford. And if we were to think of the future of India, we would never be able to provide healthcare to more than 10-15% of our population. So we started this concept of making this Institute for Integrated Medical Sciences, which then we named Vedanta when we opened in 2010. And the whole idea was to create those Cleveland clinics or the Harvards of the East. And the three ingredients that were necessary to build that was that we must build an infrastructure which can support not only the best of care, but also research and teaching and innovative thinking, provide enough space for labs, provide enough space for the training facilities, so that we could progressively train doctors who would then create medicine for India. So this process started. The second thing that was needed was to get the technology and the doctors who could then make it happen together. So we are fortunate that with the basic leaders that we got of different disciplines are to be benchmarked with anybody in the world, and collectively they become a very powerful force for developing the future of Indian medicine. And then, as I said, the technology that is required must have everything possible needed. And that is why Vedanta was actually created as a 1,500-bed institution, for the reason that you need to amortize the cost of the technology, which was 400 crores now, which actually you could build a 1,500-bed hospital just by that 400 crores, but it won't have the kind of technology that would be needed to progress this further. So this was how the whole idea came, that we create an ecosystem in Vedanta where we could progressively, by working with each other across all specialties, be able to create the new medicine which would be equally or more effective than what we are copying, but at the same time half the cost. And I'll tell you about what are the things that we are doing to bring down the cost. But just to give you an example, the Cancer Institute, and this is replicated across all other institutes that are part of the Vedanta, that you have a super specialist for each niche of that disease. So in the cancer, it will not be one cancer surgeon who will cut out everything that is needed, but you would have you would have a separate team for different parts of the body and super specialized, so that they could carry out that the research required to be able to treat the disease the way it happens in India, not the way the disease happens in the United States or Europe. Technology-wise, like this is a CyberKnife. CyberKnife has got a huge advantage. We got it a couple of months ago. Expensive, 30 crores, but at the same time, when you give radiation with that, with CyberKnife, you can actually cut down the number of treatments that you have to give to a patient from 30 to 3 days. So 3 doses of radiation, and the beam is so focused that it does not do collateral damage, so that the side effects of radiation therapy become 1/10, and the efficacy of the cancer treatment goes up 10 times. So these are the kind of things that we found, especially because in India we get lung cancer is one of the more common cancers in India than in the rest of the world. A lot of it has to do with smoking and pollution. Oral cancer is the other one from chewing tobacco. Now the treatments that you can give with this machine are much more focused to these patients who form the majority, including breast cancer. Then you take robotic surgery. So we have developed a robotic center where you can do prostate surgeries without any incisions on the body except 3 small holes. We do bypass surgery with 3 small holes without cutting the chest in the middle. We do gynecological, all sorts of surgeries with this. Now, the point is to develop your own robot, which is now what we are doing. Because this robot will cost you 1 lakh of rupees extra for the parts that you use for every operation. But if we can develop it on our own, we could reduce the cost by half. So those are the things that we are doing ourselves, including spinal surgery, including the new treatments of cancer by dendritic cells and all that. This is all being done simultaneously as we go ahead and deliver the highest end of care. And in times to come, you will see that these are all research done on Indian cancer cells, not American cancer cells. These are the problems that we have, which we need to address so that we can actually tailor our treatment. Now, stem cell research, which is limited in the United States, we have been able to do much more advanced stem cell research than most other countries. Now, most important is this, my favorite slide, that we have incorporated the treatment of, the slide keeps moving on its own, of modern medicine with IMA. Now, with the research in the last 2 years, we already have had great success in Parkinson's, we have great success in Alzheimer, in 3 other diseases of neuromuscular, so that you can actually reduce the toxic drugs that we use by half and improve the efficacy of the treatment by 2 times. So we are already beginning to see the signs of fusing in traditional or herbal Indian medicine with modern medicine, which may be the future for India, because we need to reduce the cost of Indian medicine to half at least if we are going to reach the last man standing on the Indian soil. Telemedicine is another thing that we have used now very effectively in treating patients. So 90% of your diagnosis can be made remotely by telemedicine. So this is a very big tool to reach the rural population. Second, of course, you will see that we have made alliances around the world to develop research and do more and more development for India itself. Now, what I think with all that is happening, as I told you, about our realization of where healthcare needs to go, about our realization of doing research ourselves, that I think eventually, as I said, the slide moves faster than I want it to, that all these gaps that we talked about, we can fulfill by this pyramid what healthcare should look like now. And in that, we feel that primary healthcare will have to be in the domain of the government. The secondary healthcare will have to be with the government and private sector coming together in a PPP mode, and the tertiary care will predominantly be in the private sector. So all of those who are in here, either intending to be doctors or are interested in development of healthcare, this slide will give you a little bit of guidance on where one wants to get involved so that you can actually participate in the growth of Indian healthcare sector, which probably will see, it's growing at about 15% a year, but the opportunities are huge. at every level, whether it be at tertiary level, at the PPP model level, or even at rural level. So that's for your business part. Now I wanted to give you some free advice because, as I also said, that last 15 years of an Indian's life are spent in some sort of illness or the other on an average. So the only three things one needs to do is to, one, incorporate at least 45 minutes of exercise in your life, whether it be a brisk walk, whether it be a jog, whether you do whatever you like to do, aerobics or whatever. 45 minutes, 5 times a week will give you the best chance of staying healthy. Second, your diet and your weight. Your weighing machine will tell you exactly where your body balance is, and the body is no secret that body is like a bank balance. If you do not neutralize what you take in, you will accumulate more and more calories and fat on your body, and that is going to be your biggest enemy, because obesity will lead to diabetes, heart disease, cancer and depression. So any disease you want to know, it is related to obesity. So that is one piece of thing that I think we should all be very careful about. It's very easy to put on weight, but it's not so easy to lose it. And for men, it should be easy because when our pants get tight, you know you want to miss the next meal. Unfortunately, our women don't get that feedback because their apparel is expandable, so they don't get that feedback that men do. So women have to be more careful. And the best way to stay careful is to have a weighing machine in your home, in your bathroom. And if you weigh yourself every day, you know that if you are putting on weight, you want to go slow on the eating, and if you have done okay, then you can eat normal food. So I think that's important. The third important thing is stress. And stress, as you all know, is all pervasive in everybody's life, some way or the other. And the best way to break stress is actually to meditate or yoga or entertainment, whichever you like to do. There's no hard and fast rule, but unless you break your daily routine and you go away or distract your mind from stress, you will then feel the effects of accumulated stress which causes every disease. Now there are stresses, like I said, which are pervasive, and there are stresses which are self-created. And the self-created stress comes from three things. First is greed, second is arrogance, and third is jealousy. Now, when they did the gene mapping in the world, they found Indians had 2 extra genes, and that was the J and K. J is actually for jealousy, and K is actually a misunderstood word. It's said kanjar, but kanjar is actually that you don't feel good about other people's life. You don't feel good about other people's happiness. And if you can master these 3 things, that's the best stress reliever you can be for yourself. Thank you very much. I really appreciate that, and I'm fortunate that you guys invited me. They say I'm the first medical guy here. Although till yesterday I thought IMA meant Indian Medical Association. Then they told me last night that it is a management association. But if I have not covered what I would have covered if I had known this earlier, I would be happy to answer any questions that may be for 5-10 minutes if you so desire.